It's been called our body's most underrated organ, and we need to hear what it's telling us. Listen to your gut. Tonight, On Call with the Prairie Doc. On Call with the Prairie Doc. I'm Dr. Andrew Ellsorth, your Prairie Doc this evening. The gut is often referred to as our body's second brain. Tonight, we're talking gastroenterology. But first, a look at this week's Prairie Doc quiz question. It is a true or false question. The rate of people being diagnosed with colon or rectal cancer each year has dropped overall since the mid-1980s. True or false? We'll give you the answer at the end of the program. Joining us tonight in the studio is Dr. Sarah Bligh, who practices gastroenterology at Midlands Clinic in Dakota Dunes, South Dakota. Welcome, Dr. Bligh.
Thank you.
So, Sarah, tell us a little bit about yourself.
Well, as you said, I'm Sarah Bligh. I am originally from Coleman, South Dakota, where my parents still live. And I did my undergraduate college training as well as medical school at University of South Dakota. And then my internal medicine and gastroenterology training down at University of Nebraska Medical Center, and have now found my home and my niche in terms of both family and work practice in the Dakota Dunes, Sioux City area.
Okay. So are you mostly in the Dunes, mostly in Sioux City, or how does that work?
It's a pretty even split. I see all my clinic patients in the Dunes, and we do have a procedural center there, but I do also service both of the hospitals that are located within Sioux City proper.
Okay. And so what is gastroenterology?
So gastroenterology is the medical study and treatment of any disorder of the gastrointestinal tract, which includes anywhere from your swallowing tube, esophagus, stomach, your intestines, as well as the liver and pancreas organs.
And what made you decide to choose gastroenterology?
That may be a little bit different story, I guess, than most. I went to college thinking I was going to be an eye doctor, and then I got involved in a research lab where we studied GI physiology, gastrointestinal physiology, and I found it really fascinating. And so then all the way through medical school and residency, that was always just the part that was calling to me. So
cool.
Here we are.
And now that you've been practicing for a while, what do you find most rewarding?
I would say I have two answers to that question. One, it is extremely rewarding to prevent colon cancer. When people have their colonoscopies and you take out those polyps and you know you're making a difference in that one person's life that day. Mm-hmm. Mm-hmm. The other thing is I have always found, even when I was in my primary care days, that it was very rewarding to see a patient in the clinic and make an intervention that would make them get better and actually stay out of the hospital. So that's still something I get to do on a day-to-day basis.
Yeah. Along those lines, one of the things I can think of gastroenterology that, in the clinic you can make a difference and prevent some complication is ulcers and heartburn and reflux.
Mm-hmm. Very common problems that we see in GI every day.
What do you usually recommend for treatment? How do you approach that usually?
Well, it depends a little bit on the severity of someone's symptoms, the frequency as well. For people who have occasional heartburn from time to time, it may be as simple as avoiding the foods that trigger it, or taking a simple antacid when the symptoms come on. But if you have very severe or frequent symptoms, it is likely beneficial to take an everyday preventative medication.
Some of the foods, some of the things you might look for that are triggers would be what?
The most common triggers would be spicy foods, tomato-based products, citrus fruits such as oranges, pineapple, grapefruit, things like that. And some people are very triggered by chocolate, although that is less than other people. Coffee, one of my favorites.
Yeah, it is amazing. It does seem like more and more people are drinking coffee or, all the lattes and stuff, and then more and more of it. And it is amazing. I think caffeine is starting to cause more issues with reflux for some people.
Yes, caffeine, and that's the interesting thing about coffee is that caffeine is a trigger as well as the coffee itself is fairly acidic. So so it's kind of a double whammy if you drink the fully leaded coffee.
Do you think alcohol is much of a trigger too?
Alcohol is a big trigger, and actually not a food, but smoking as well.
Yeah. Yeah. So working on lifestyle changes, probably losing weight.
It's true. If you carry especially extra weight around your midsection, that puts a lot of pressure up on your diaphragm, which can cause more reflux disease.
Certainly some people have a hiatal hernia. How does that contribute to reflux?
Sure, so it's a predisposing factor, something that might make you more likely to have it. And what it is your diaphragm that separates your chest cavity from your belly cavity has a small opening in it that allows your swallowing tube to come through and meet up with your stomach. And over time, that opening can sort of get stretched out or be too big. And then that is what allows your stomach to slide up into your chest cavity. That's what a hiatal hernia is. And then that diaphragm is part of your body's natural barrier that helps to keep all the acid that's in the stomach down in your stomach instead of being up in your throat. So now if some of your stomach is sitting up here in the chest, that acid has free access to come up.
So when someone has that, are you more likely to recommend medication or surgery, since there's kind of a structural thing?
Sure. And that's an excellent question, because actually the other part that is one of the biggest contributors to reflux disease is also a structural thing, and that's the muscle at the lower part of your esophagus. It's the gatekeeper. It's supposed to just be open when you need to swallow or belch or rarely vomit. But in people who have reflux disease, it's often opening more frequently than it's supposed to. So it really is, a lot of the issue is anatomic. However, we have very strong, effective medications that can manage reflux symptoms and complications very well, and so most people don't require surgery for this issue.
And so those medications like Prilosec or Nexium, Zantac, or Omeprazole, so on, the generic names. But, some of those have gotten a bad rap lately. Why is that?
Well, in particular, the Zantac, since you mentioned it, is one that essentially there's different chemicals that are sometimes in pills of all sorts that may not be necessarily a known cancer-causing agent, but there's enough data to suggest maybe. And since we don't really know, the FDA says, okay, you can put that in your pill if you have to, as long as you keep it below a certain amount. But any company that's going to do that, they have to do quality control. And essentially that particular drug is one that failed its quality control. And so there was more than the acceptable amount. Now, does that mean it's a risk amount? We'll never really know. The good news is we're getting it out of the world so that we don't have to test that fact.
And the generic there was ranitidine.
Correct.
And, I think in the end, it's not really the medicine that did it, but how to make it into the pill.
That's exactly right. It's not the chemical compound that was fixing the heartburn that is this potential cancer risk. It's additives in the pill. Yeah. It's a similar additive that was in, and there's a popular antihypertensive that got pulled a couple years ago. I can't remember which one it was now.
Yeah, there's a combination, lisinopril and hydrochlorothiazide for the combo. So then I had to prescribe a bunch of people them separately.
Right, because the drug that's doing the job was safe. Yeah. It was the house that it was carried in that was maybe not.
So it seems like probably more effective is the PPIs, proton pump inhibitors, omeprazole, and so on, in that ozole family.
Correct.
How do they help, and do you often recommend those then?
I do, and they're often the most effective acid reducer around. And the reason is your stomach makes these little pumps that churn out the acid. And what these medicines do, that's why they're called proton pump inhibitors, is they shut down the production of the pump that creates the acid. So they're really very effective at cutting down or limiting your stomach acid compared to the other ones mentioned, ranitidine, or what most people use at this point in time, which is famotidine or Pepcid. Your pumps still make the acid, but they turn off the signal to release it. And then things like Tums, Rolaids, Alka-Seltzers, just kind of back to good old-fashioned high school chemistry, acid and a base that neutralize it. And so the omeprazole is really the similar drugs in this category is really the most potent acid reducer.
And what are some of the reasons we don't want to be on them long term if we can help it?
Right, so your body uses stomach acid to absorb calcium out of the diet. So if you're on these medications for many years, you do end up accumulating some risk about not absorbing enough calcium to keep your bones strong and healthy is the biggest risk factor with these medications.
Yeah, and of course, it's strong, healthy bones is good, so you don't end up falling and breaking a hip someday.
Correct.
Or anything. And I don't know if you've seen that calcium in your diet in general is more helpful than calcium pills. The pills are actually, from what I've heard, more likely to end up in stones, kidney stones, or your arteries, as opposed to in your diet. And I don't know if you've done any research of that. But
I haven't necessarily done research in that specifically, but I would say I would agree with that. And a lot of it has to do with the dose. You're taking a very large dose at once, which actually your body can't even absorb the full amount of calcium that's in one tablet at one time. It's part of, if you think back to being very young and learning about 3 servings of milk or calcium a day, and it has to do with how much your body can absorb at once. It's not that you need so much that you have to have it in 3 doses. It's that separating it out makes it really more able to come into your body.
One more question about heartburn and reflux and ulcers, which sometimes can form.
Yes.
If from eating away, and then you get this ulcer, and then they can bleed.
Yes.
It seems like some people that have a lot of anxiety get ulcers. Are they related?
Anxiety or emotional stress of any kind does not cause an ulcer, but it can exacerbate the symptoms of an ulcer. The 2 most common causes of ulcers are actually a bacterial infection called H. pylori, and then very common arthritis medications such as ibuprofen and Aleve. Physical stress to the body can cause an ulcer, so sometimes when people are sick or in the hospital, we'll put people on acid reducers to make sure they don't get an ulcer while they're ill.
Do canker sores fall in that same category then, basically, as far as
canker sores are a totally separate deal. They're totally different kind of ulcer.
Because I've seen them come from stress too, but
they are often triggered by stress. Both physical and emotional stress can trigger canker sores.
Yeah. Well, should you be diagnosed with colon cancer, there are steps that are part of the treatment. Your oncologist will help you through the process that has historically good outcomes.
I was diagnosed in February of 2015. Really did not have any signs. It was a matter of I had turned 50 and I was in the last month of my 50th year, as they say, and I knew that if I didn't have my colonoscopy, my mother was going to schedule one for me and would go with me to the doctor and embarrass me. I had my colonoscopy on Monday morning, and I knew by Friday that I had cancer, and it was rectal cancer, and literally the ball started rolling as, you'll need to have this appointment, you will receive a phone call from this doctor's office, and it began. Then I started meeting with oncologists, and the oncologist had me meet with my surgeon, and I had a port put in, and that would be for chemo, blood tests, any of that. They would just use my port instead of going through veins. And honestly, it moved pretty fast because once it was determined that I had cancer, there was no waiting. Process began. I have an ostomy. So they removed part of my colon and my rectum, and I have a permanent ostomy. Options were that they would go in, and option number 1 is remove the cancer and everything would be fine. Realistically, option number 2 was going to be they would put a temporary ostomy. And 3 was they would have to do permanent. And the decision was made before my surgery that if that's the case, the doctor had permission to proceed with having a permanent ostomy put in. I actually was cleared in 2020. is when we had my final CT scan. All my blood work was done. They were not detecting any cancer at all. Everything was going quite well. So I've been released from my oncologist. We go back to the care of the primary doctor. So my advice to anyone is to have a good relationship with your primary and do what you're told, because my primary was also pushing me to have a colonoscopy when I turned 50.
That was an interesting graph they had there of showing colon cancer rates increase as you get older. And thankfully, colonoscopies and colon cancer screening have helped to decrease the rates overall, but we are seeing in some younger people. Why do you suppose that is? Do you know?
That is not completely understood at this point in time. It is likely linked to something, whether it's in our diets or our environment in some way, that tends to be turning on these genes at an earlier age that cause these mutations in our body to make these polyps and things. But it is the reason why the screening recommendation is changing from age 50 to 45.
Yeah, and that hasn't caught on with some insurance companies
That's
yet,
correct.
Unfortunately. Definitely it's easier if someone has a family history of colon cancer, of getting them an earlier colonoscopy. But in general, they're starting to recommend age 45 for everyone, even low risk. But are you finding you can get the insurance companies to prove that yet or not?
I would say it's very variable, and it's generally what we recommend when people are trying to schedule it before age 50. We just recommend that they call their insurance and find out if it'll be a covered benefit or not. Now, certainly because we recommend it, I would still always offer it to a patient, but they need to be aware that there could be some cost to them.
Okay, and of course every situation is different for people, and they should talk to their doctor when they recommend having it done. If someone has a family history of colon cancer, what do you generally recommend when they start screening?
It does depend when their family member actually had colon cancer and what degree that relative is to them. So generally increased screening is recommended if it's a first degree relative, such as your parents' siblings. And if they had it at a young age, say 50, then you'd want to begin usually 10 years before that age. So even as early as 40, you might be screening. Or if somebody has a very young, in their 30s or 40s, it may be even earlier. So generally at least 10 years before the age when they had the cancer. And then your screening needs to be more frequent as well. If you have a family member, we generally recommend, even if you have a normal exam, that you come back every 5 years, because you may be at an increased risk.
Why is it that some people are supposed to come back after 3 years, sometimes 5 years after colon polyps?
Sure, it depends on
even 10 sometimes.
Yeah, it depends on the number, the type, and the size. So most colon polyps are either what's called an adenoma or hyperplastic. These hyperplastic polyps are not precancerous. In theory, they could live in you for forever and never cause a problem. We can't tell for sure when we're looking on the inside, so we just take them all out regardless. So that's where you might have polyps and they might still come back and say, hey, you can come in 10 years. These adenomas are precancerous polyps. Again, they're not cancer yet, and we take them out, so that one's not coming back. But the idea is if you grow another one, we want to make sure that when we come back, it's still just a small polyp and not something more serious. And if they're larger than a centimeter or a particular high-risk type of polyp, that's when we might say 1 year or 3 years come back, versus if it's a standard adenoma, it'd be a 5 years.
Yeah. What do you think about some of the at-home colon cancer screening kits?
Well, I'm a little bit biased on that front. I would generally recommend that you come for your colonoscopies, but that being said, they're not invasive. So every invasive procedure does have some risk. Colonoscopy is fortunately a very low risk procedure, but obviously more than not undergoing a procedure. So it does have that advantage. The disadvantages are there's a little bit higher false negative rate, meaning you could have a negative test when there was in fact a cancer on the inside. It's still very low and uncommon with those tests, but more so than with a colonoscopy. And then the final thing to consider is that those tests are truly just a screening test, where the colonoscopy is both screening and preventative, because you can take the polyps out and prevent cancer, where if you have the screening test with just polyps, it will usually be negative. Some polyps will turn it positive, but usually be negative, and so then you haven't done anything to prevent your chances of getting cancer down the road.
Right. Yeah, I have to admit I'm favor the colonoscopy too for that reason. I mean, that's the whole point. Let's catch this early and do something about it early on, before it grows into something. But the best colon cancer screening method is one that gets done.
This is correct.
And so, if you have whatever reason you really don't want to do a colonoscopy, if you'd please do that.
Yes.
At least then you'd have some benefit. I might note that sometimes insurance, if they approved you having an at-home colon cancer screening kit as your screening that was covered under your insurance, then they sometimes won't cover the colonoscopy if it ends up showing something or being positive. Have you seen that?
We have seen that, and that will happen every time, because now your colonoscopy is no longer for screening. Screening means no symptoms, no problems, just average risk. The fact that you had a positive test means that there's an abnormality that we're looking into.
Yeah.
And so that's why it ends up being a diagnostic exam rather than a screening exam, and usually going towards someone's deductible on their insurance.
Going back a little bit, what is a colon polyp?
Sure.
And what causes colon polyps?
So colon polyps are little growths in the skin lining of your bowel. You have a skin on the inside, just like inside your mouth, all the way through. And they're just little growths that start out even just as a small little couple millimeters, can grow into almost looking like a mushroom shape. And it's just an overgrowth of skin that, because of some errors that it made in how it grew and divided abnormally. And in terms of sort of reducing your risk of forming polyps, some of it's genetic, you can't control that, but not smoking reduces colon polyp risk, eating a high fiber diet, and limiting processed meats, all are things that have been shown to reduce the risk of polyp formation.
Yeah, so get screened.
Yes.
I would like to talk about probiotics a little bit, because I get asked about those a lot. What do you recommend for probiotics?
Probiotics are interesting because there's a lot of research out there about probiotics, and it's nearly all positive, meaning they're good for you. However, in terms of which one is the right one or the best one, we don't know. Yeah. There's just so much differences between how all the research trials were done, what types of bacteria, how many, was it a live bacteria or a dead bacteria, to know what is the best. And so in general, I think that the best data is behind lactobacillus, like that comes from milk, that lacto word, and then one called Saccharomyces, which is a bread-based bacteria.
Is it to the point where you'd recommend probiotics for everyone, even if they've never had an issue?
Yeah.
Or?
I think of a probiotic kind of like you would take a multivitamin for your general health, but this is for your gut. So we can all get all of the vitamins and minerals and nutrients that we need in our body through our diet. Do you need a multivitamin? Maybe not. But we all live a crazy busy life. Some days you eat better than others. And so it's nice to have that insurance policy. So probiotics kind of the same way. It's very much good for you, but if you eat lots of fruits, vegetables, high fiber diet, you're probably getting everything you need in that regard anyway.
Okay. Yeah. And I sometimes add, certainly say if someone's on an antibiotic, there's a good reason to be on a probiotic.
Very true. Very true.
Yeah. I want to go back talking to Dave Heim, good friend of mine, and he did such a great job. We made this into 2 roll-ins.
Right.
So it is important to find out early if you have colon cancer and begin treatment. It is also important for your well-being to find out if you don't have it.
I think it's very important. I was very fortunate because I had stage 2. I would not put it off. I would not recommend to put it off. Having a colonoscopy, it was a very simple procedure. Yes, there's the issue of the cleansing the night before, but in reality, it's really, with everything that I've gone through, that's an easy step in the process. What I'm hearing now is if you have history in your family, then by all means, if you have colon cancer, by all means, you need to talk to your primary, and you and your primary should determine when you should have your colonoscopy. The purpose of getting a colonoscopy is to make sure that you do not have colon cancer, or it is more important for your personal health so that you don't have a progressed cancer that you were totally unaware of. Like I said, I was fortunate. I went in for my colonoscopy. I was at stage 2. Some people are at stage 3 and 4, which is much more serious. In and out in the morning, they kind of caution you to. I took the full day off, and so to recover and. And I'm glad I did because of, we had to do a biopsy. But most people have it done and they're good to go. I thought, why did I put it off? I made such a big production overnight. It was like, but I knew I had to have it done, so I waited to the last minute. I would encourage you not to. If your primary is telling you to have your colonoscopy, then by all means you need to get it scheduled. I think it's important because if I would have waited, it could have been worse. We don't know. Every person, I believe, is different. Like my oncologist says, because you have rectal cancer, you're not the same as this other person who has it or another patient that he has. So you really get to know your oncologist and your staff to know more about yourself, I guess. Cancer is what it is. And I had another cancer survivor tell me, she said, it will be a year out of your life. Just fight it like you've fought everything in your life, just fight it. And what happens, happens. It is what it is.
Thank you very much, David. Thanks so much. That was great. One point that he had brought up is that his mom had encouraged him to get it and was the one that got him to do his colonoscopy. Mm-hmm. And how important that is for so many things of someone's health is when they have a family member kind of pushing them on. Mm-hmm. So if you know someone in your family that they need to get it done, go ahead and nag a little or encourage them, because it could really save their life and make a difference.
It's true.
Yeah. Let's move on to celiac disease.
Sure.
What is celiac disease?
Celiac disease is an autoimmune condition. Autoimmune means that your immune system is sort of attacking part of your own body. And it is triggered by eating products that contain wheat. So it's a complete intolerance to any food that has wheat in it, such as bread, pasta, things like that.
Yeah, that gluten protein.
Correct. That's the component of the wheat that is triggering the disease.
And how might someone know, if they're listening to their gut, how they maybe might have celiac?
Sure. The most common symptoms of celiac disease would be diarrhea, abdominal pain and cramps, bloating. Sometimes a lot of fatigue goes with it.
Is it something a person's going to have their whole life, or can you get it even later in life?
It is something that a person's actually born with the genetics to have it, but it shows up at some point. The most common age would be teenage years to age 20s, but it can be diagnosed at any age. Sometimes people will live most of their life into their 50s, 60s even before it shows up.
And how do you diagnose it then?
It can be diagnosed by blood test, often is enough. Sometimes then it's confirmed with a scope going down into the stomach and upper small bowel to take some biopsies.
Now, I've had some patients that, they had the test done, they don't have celiac, but they went on a gluten-free diet and they felt better. Why would that be?
I think that it really relates back to irritable bowel syndrome. In GI we would talk about non-celiac gluten sensitivity for a long time. And then the Fodmap diet, which is part of the treatment for irritable bowel syndrome, was discovered. And what that has to do with how the bacteria that live in your gut digest different starches and sugars that you eat. And gluten is one of those chemicals that bacteria make a lot of waste products when you eat gluten, and sometimes that can cause a lot of excessive gas, changes to your bowel consistency, and general abdominal discomfort.
Yeah. So once they, for celiac and gluten sensitivity, once they stop eating gluten, they feel better.
Correct.
Now going to irritable bowel syndrome, what is that?
So irritable bowel syndrome can be characterized by having altered bowel habits, and that can be either diarrhea or constipation, or sometimes people flip back and forth between the two, and usually accompanied by some degree of abdominal pain. And there would be an absence of any kind of inflammatory disorder inside the body.
And so, they've had the tests and done the studies and everything's comes back normal then.
Yes, exactly. So just because everything comes back normal doesn't mean everything is normal. It's kind of what I tell people. It doesn't mean what they're experiencing is normal.
Yeah.
But that is the hallmark, that there's no breakdown. Nothing is being destroyed on the inside, which is good because it means the danger level of irritable bowel syndrome is very low, but symptoms can still be very high.
Yeah. Are you seeing some good benefit from the Fodmap diet then?
We do. It really makes a big difference in people's stool consistency as well as their bloating and abdominal discomfort for most people with irritable bowel.
Is there any other treatment for it that you found helpful?
There are many other treatments that are out there. Some of them are focused on treating the form or consistency of your stool. If you're having a lot of loose bowel movements, you might need to be on a regimen of anti-diarrhea pills, or conversely, if you have a lot of constipation, you may need to be on increased fiber or even some laxative medications. And then there are other prescription medications that can help with the discomfort. And finally, physical activity is very helpful.
Yeah.
And getting good rest at night.
Yeah. Sometimes antidepressants are helpful. Now, why would that be?
Again, it goes back to the pain component of irritable bowel syndrome. Pain is a very common feature of it, and many antidepressants actually have activity on the pain receptors inside the body. So it's not so much that we think you're secretly depressed, or that we're just turning something off, in your brain, in your mood to not be in pain. It's that they're really working on those pain receptors. And similar medicines get used for other types of pain too, migraine headaches and chronic leg pains, things like that.
That goes back to the show. We're talking about listening to your gut and your second brain.
There you go, that's true.
Those receptors there. Yeah. So, if someone comes in with blood in their stools, what goes through your mind of what might be going on? And is that something they should get checked out?
Yes, that's what I was going to do. The first thing I was going to say was blood in your stool is never normal.
Yeah.
It may not. There are some things that cause it that are not dangerous, such as very common hemorrhoids, for instance, but it's never quite normal. And so it is something to have checked out or talk to your doctor about. If it's bright red in color and not a large volume, hemorrhoids or varicose veins around your bottom would be the most common cause of it, but it can, especially when it's dark or tarry looking, could be a sign of an ulcer, as we talked about earlier. And blood, whether bright or dark in color, can sometimes be a signal of a large polyp or cancer on the inside. So again, things that should all be evaluated.
And diarrhea and bloody stools. I'm getting at is, what if they have inflammatory bowel disease?
Sure, some sort of colitis.
What is that? Yeah.
So inflammatory bowel disease is another autoimmune condition, or condition where your immune system, instead of fighting some infection or cancer or something foreign, it's fighting your own intestines and breaking it down. And the difference, as we talked about irritable bowel syndrome, where there's no damage on the inside, in these conditions it's actually breaking it down, making ulcers, making holes, things like that on the inside. So it can be very painful.
It seems like we've seen more of that. Are we just diagnosing more, or are there more people with it for some reason?
I think it's a combination. Anytime awareness goes up about a condition, you are going to diagnose more of it. More people, and the public being more aware, you're more likely to come in and have your symptoms evaluated. But I think, especially in the case of one particular type of inflammatory bowel disease, ulcerative colitis, there are many environmental factors that contribute to it. So there are obviously things that are changing in the world around us that are triggering some of these things.
So with ulcerative colitis, what is some of the symptoms of that, and what do you end up seeing on a colonoscopy?
Sure. So again, symptoms would be bloody diarrhea is really the hallmark of that one. Often a degree of abdominal pain. Sometimes people are even losing weight because of the amount of damage that's happening on the inside. And when we look inside with a colonoscopy, instead of seeing a nice, smooth, pink lining, almost like you might see if you looked at the inside of your mouth in the mirror, it would just look very raw and red. Sometimes always gets described as looking like raw hamburger or something like that. I mean, it's really very, very abnormal looking on the inside.
Yeah. And what helps with that then? What's the treatment?
Medication therapies. Some are pill medicines and some are even IV therapies.
Okay. And to kind of suppress the immune system.
Correct.
And
So,
anti-inflammatories, steroids.
yes, exactly.
Yeah. And so as opposed to so that's ulcerative colitis, but
Correct.
as opposed to Crohn's disease, what's the difference there?
The difference, ulcerative colitis and Crohn's disease are really very similar, and the trigger is very similar in terms of coming from your immune system. However, the location and pattern to the damage on the inside is quite different. The ulcerative colitis is just in your colon or large bowel, where the Crohn's can be in the small intestine, stomach, anywhere throughout your GI tract. And the depth of injury is much more in Crohn's disease and ulcerative colitis.
Okay. And the treatment then is the same?
Treatments are very similar. Ulcerative colitis sometimes can be managed with high-dose anti-inflammatory drugs alone, as opposed to immune suppression, where Crohn's always requires an immune suppression, but really the same medications are used to treat both illnesses.
Hepatitis C is something that I understand you help treat.
Yes.
In Sioux City.
Correct.
And so who do you recommend getting tested for hepatitis C, or when or why?
Well, the guidelines at this point in time from the CDC is that really anyone of that baby boomer generation should be tested regardless of risk factors. We used to screen people for risk factors, which would be anything that would put you in blood-to-blood contact with another person, such as a blood transfusion, history of needle drug use in the past, maybe even something such as being in a really bad car accident where there was blood exchange. There's a variety of ways it can happen. So we used to screen people for risk factors and then just test people based on that. But we've really found that there are a lot of people you can't trace back and figure out where their infection came from. A lot of that probably has to do with changes in infection control practice in medicine over the years. And so anyone in that age range, it's recommended to be screened at least one time regardless of risk factors.
Because they can have it without knowing it.
It's true. It is an illness that really does not cause symptoms until it's really caused a lot of damage. And so people often have it even for decades before they know that they have it and are sick.
And being a hepatitis, it's a liver disease.
Correct. Chronic virus of the liver.
When I think of way back when I was in residency training, I did help cure some people with hepatitis C. But it was quite the regimen, and with a lot of side effects.
That has changed.
I've
Thank
heard.
the Lord.
Yeah.
When does that happen, right? We have medication that's easier to tolerate and does a better job at curing it. So in the past, there was a lot of injection therapy that was used, and it caused a lot of side effects. But the pill regimens that we have now have, for most people, more than a 95% cure rate with limited or no side effects.
Yeah, and I mean, this is a disease that wreaked havoc on a lot of people before. So that's good. So get
and
tested.
It's curable. It's not a suppression thing. It's once you treat it, it's gone.
Yeah, excellent. Say, as a GI doctor, in general, what do you recommend people to do for their GI health?
I would say lots of fiber in the diet and drinking a lot of water are the two biggest things that anybody can do. It helps many different aspects of your GI health. And yes, there's some conditions that we just talked about that that didn't even enter into what I was talking about the treatment. So there are certainly, and there are times where that may not be enough, but it really will help everyone to have lots of fiber and fluids.
With COVID-19, are there some conditions you've seen more of now, maybe either because of the virus and because of the way society's changed, maybe?
I would say in the GI world, there may not be as much impact as some others, such as lungs and heart. There's a lot of heart complications that are coming in. There certainly have been, we talked about those types of autoimmune colitis. There is colitis that can be caused by COVID-19. And something that will be yet to be determined as time moves on is in that time period of 2020 when our healthcare seeking practices were different, much less. You know, are there people who had mild disease that has now advanced to something much more serious because of that? There may be some.
Yeah, I mean, definitely there was a period of time where people weren't coming in. The doctor's offices were telling people not to come in.
Exactly.
Or doing more virtual visits and not getting hands on the patient and helping to detect things and some preventative care. So yeah, hopefully that is not affected too much. We were talking about irritable bowel syndrome there, and we talked about the Fodmap, but we didn't really explain it much.
Sure.
Let's go back to that and explain what that diet is.
Well, it's a little bit complicated one, actually. So that's okay. It's not as simple, and that's kind of what I tell people on a day-to-day basis. It's not as simple as saying go low fat or eat more fiber, things like that. It's actually a very particular list of which fruits and vegetables and wheat grain products have higher amounts of oligosaccharides, which are the types of sugars and starches, versus lower amounts. Now, if you're on this diet, it's not something so much so that eat these foods and you can never eat these foods, but it more points out with a pattern that can be difficult to figure out on your own what foods might be triggering you.
Do you end up sending them to a dietitian kind of to go through that if they can?
If their insurance will cover it, we do send to dietitians. Otherwise, we carry a lot of information at our office that we'll either send home with people or mail to them for them to study, and certainly we talk about it at our visits too.
Many of our viewers are across South Dakota, and some are further away from a gastroenterologist or a dietitian for that matter. Any resources in particular you would recommend to them to maybe try that diet or to get help for whatever, diet changes?
Well, if you have access to the web, the internet in any way, you can really just look it up. Fodmap, it's like food map. I tell people because it's kind of your map of your food, but leave out one of the O's. And it's something that's pretty well out there. But if you were having a difficult time finding that information, I'm sure your primary care doctor could offer it to you as well.
Constipation.
All right.
I can't believe we haven't talked about constipation yet.
It's very common. It's very, very common.
What do you recommend for constipation?
And so, like most illnesses, it's something that will vary greatly in severity from person to person. The first steps for fiber and fluids, as I talked about, making sure you're getting adequate amounts of both of those in the diet. Staying physically active helps to reduce constipation as well. And when that's not enough, then sometimes people need to move on to medications, whether that's over-the-counter or prescription therapies. In general, it's recommended that you find a regimen to help your bowels to move a minimum of twice a week, though many people will need to go more frequently to feel comfortable.
Yeah, people talk about being regular. What's regular?
It varies very much from person to person, and so you don't always have to have one perfect bowel movement every morning. Some people go 2 and 3 and 4 times a day, and that can be very normal if the form is normal and they're not having a lot of symptoms. And likewise, some people may only go every other day. But again, as long as they're not straining or having a difficult time to pass that stool, that's okay. That's regular for you.
Yeah. Going back to some of the hemorrhoids, bleeding that we were talking about, constipation is definitely related to that. That can also contribute to causing anal fissures.
Correct.
What is an anal fissure?
Sure. An anal fissure is just a tear in the skin around the opening where your stool comes out. That usually would come from an episode of either straining, pushing very hard to pass a stool, or a stool that's very dry or dehydrated can tear things as that skin stretches to let it come out.
Yeah, I've often had patients describe it as pooping glass.
Yeah.
And so how do you treat that?
Sure. So to get through that fissure and get it closed, there's a lot of topical therapy that can help reduce the pain, swelling, and irritation around it. But the biggest thing is to get the bowel pattern regular again to prevent that from happening, because your skin will actually heal very quickly. It's just like a cut almost anywhere else on your body. It takes only but a few days for it to heal up. But if you don't take away that force that's causing it, it's just going to happen recurrently.
Yeah. What are some changes in the practice of gastroenterology that you've seen in your career?
That's a good question.
Sorry.
No, that's okay. So, I mean, there is certainly more women in the field, I would say, as time goes on, which I think is great, being one myself, obviously. But, and then I think it's just all the new discoveries that come along. You know, we've touched on a few of them over the evening here. Hepatitis C, we didn't know about until in the 1980s. H. pylori bacteria, that's one of the primary causes of ulcer. We didn't know until within the last 40 years or so.
How can someone get tested for that?
There is a stool test or a breath test that's very reliable. If you're ever having a scope to look for ulcers, it would also be tested through a biopsy there.
And then how do you treat that?
It is a course of the acid reducers like omeprazole, Prilosec we talked about, plus 2 weeks of antibiotics.
Very good, very good. The other thing we didn't really talk about much was diarrhea. So when someone has diarrhea, what are some treatment recommendations you have for them?
I'm going back to the fiber. It sounds a little bit odd, but it's the one thing out there that can actually treat both the constipation and the diarrhea. It helps soften the stools and pull the water. It pulls the water, it attracts the water. That's how it works. So when your stools are too hard, it pulls water into that hard stool. When your stools are too loose, it attracts that water to kind of form it up and get it to come together a little bit. And you know, so that's a good place to start. Abnormal diarrhea that you should always talk to your doctor about would be is if you can't get to the bathroom in time, or if you're waking up at night to poop. Those things are less common with these more milder types of diarrhea that can be managed by your diet or even some over-the-counter anti-diarrheal medications.
So fiber.
Fiber.
Fiber in what foods?
Fruits, vegetables, whole grains.
Yes, so healthy diet, exercise, water, salt, and don't spend too much time on the toilet then, right? Sounds good.
That sounds
I
good.
really appreciate you coming in, Sarah, and it's just been so fun to be in practice now for a while and having a lot of our fellow. We were classmates in medical school together, and many of them have come back to South Dakota from going elsewhere for residency and stuff, and just catching up in our professional lives now.
It's true. There's another med school classmate of ours that actually my cousin's wife messaged me on Facebook one day to say, I saw you're friends with them and I was looking at them to be my doctor. What do you know? What can you tell me? And of course I said, go right ahead. He's great.
Well, thank you. And now for the answer to tonight's Prairie Doc quiz question, true or false? The rate of people being diagnosed with colon or rectal cancer each year has dropped overall since the mid-1980s. True or false? And the answer is true. According to the American Cancer Society, the rate of people being diagnosed with colon or rectal cancer each year has dropped overall since the mid-1980s, mainly because more people are getting screened and changing their lifestyle-related risk factors. But the lifetime risk for men is 1 in 23, and for women it is 1 in 25, so get screened. We'll be right back after this.
For nearly 2 decades, the Prairie Doc organization has endeavored to enhance health and diminish suffering by providing useful information based on honest science in a respectful and compassionate manner. Health professionals volunteer to answer your questions each week, creating a vast Prairie Doc library of medical information available to you and your family 24 hours a day. Make sure you don't miss a thing. Follow the Prairie Doc on Facebook and YouTube for free and easy access to the entire Prairie Doc library.
We all know the feeling. You ate too much and now your stomach is letting you know about it. Or maybe you ate some junk food and now you don't feel well. How is it that another slice of pizza one moment seems like exactly what we want, but later we realize it was not what we needed? In the simplest of terms, it comes down to hunger and cravings. The message for hunger is initiated by the body. When our stomach is empty and our blood sugar and insulin levels begin to drop, our bodies release the hormone ghrelin and send it to the hypothalamus in our brains, resulting in a desire to eat. Cravings, however, are entirely controlled by our brains. Fatty and sugary foods help release feel-good opioids and dopamine in our brains. The message in this case is a misapplied sense of reward. Our bodies, especially the gastrointestinal system, respond directly to what we put into them. Many common problems like abdominal pain, heartburn or reflux, constipation, and diarrhea are often directly caused by our diet. Other conditions like irritable bowel syndrome and celiac disease can also be treated by a change in diet. Cutting down on processed meats and processed carbohydrates may help decrease your risk of colon cancer. Thus, when it comes to filling our hungry stomachs with healthy options, there are ways to overpower the feel-good cravings from our brains. First, turn off the TV. Plenty of studies have shown that we eat more than we ought to with the TV on. That goes for your phone too. Second, slow down. Savor your food. Give your body time to send the signals from your digestive tract to your brain that you've had enough. Third, drink water while you eat. Room temperature water is best for digestion. Also, we often misinterpret being thirsty for being hungry. Having a glass of water before you eat can help satisfy your thirst and help you eat less. Fourth, eat with someone, in person, via Zoom, or phone call. When you eat with someone, you are more likely to make healthier choices and eat slower. Our bodies know what is good for us. We just need to understand the messages. Next time you have a craving or think you feel hungry, rather than automatically eating more, take time to assess your situation. If you discover you are tired, stressed, sad, angry, or lonely, appreciate your new self-awareness and explore behaviors other than eating that could better satisfy your needs. If what you are feeling truly is hunger, give your body what it really wants, a healthy diet. A big thank you to our guest, Dr. Sarah Bligh, for volunteering her time to help us learn more about the importance of listening to our gut. If you would like more information about this program, or to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. That does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
When a family member or close friend enters end-of-life health management, they move into a variety of treatment options, hospice and palliative care. Next time, On Call with the Prairie Doc.
Hello to all. I am Dr. Tom Luzier, a practicing allergist in Aberdeen, South Dakota. Born in Kansas, I embraced the diversity of South Dakota. This diversity comes with a price: limited healthcare resources and information. The Healing Words Foundation, through Prairie Doc, provides an open, online, interactive, public broadcasting format for reliable health information. As a member of the Healing Words Foundation Board, I am asking you please to join me in support of this work, which is funded entirely by donations from you. Please consider making a personal or corporate gift to Healing Words Foundation, a 501c3. Go to prairiedoc.org and click on the donate button and make a valuable contribution. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, South Dakota Foundation for Medical Care, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Sioux Falls District Medical Society, Yankton District Medical Society, Aberdeen District Medical Society, Urology Specialists, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftel Communications.